So welcome to actually the first true session of the meeting, and I'm happy to be moderating it with Nancy Mellon. And so what this session is going to be about is really the overall theme of this meeting, right? So thinking outside of just audiology and speech pathology, but really what's the role of therapy, education, and family engagement, which is really important to, I'm sure, everyone in this room. Our first speaker is Dr. Jenna Voss, and she's going to be talking about family engagement in cochlear implant therapy and educating, and focusing on promoting resilience for children experiencing adversity. Jenna?
For the time or just hit it? It's fine. Okay. Okay, good morning. It's a pleasure to stand before you today to commence our morning of learning about the way our systems and services might better engage families of the children on our caseloads and in our classrooms. Yes, my disclosures are here, and I'd like to briefly acknowledge that this work has been that of an important collaboration and mentoring by my dear and beloved Dr. Susan Lenehan, who's unable to attend the conference in person. In these brief few minutes, I will incompletely address the objectives listed on the screen. So today, I hope to stimulate your thinking about how we can better serve children and their families who are experiencing adversity. No doubt, these children and families are served by your clinics and on your caseloads, and their experiences outside of our service delivery settings have a profound impact on their listening, language, and communication outcomes. The term Adverse Childhood Experiences, or ACEs, was first used by Folletti and Anda, who conducted a large public health study and found that individuals who were exposed to trauma before the age of 18 were negatively impacted. These researchers ended up identifying 10 categories of trauma that impacted health outcomes and found a stunning link between childhood adversity and health, as well as social and emotional challenges. The data reported by the Health Resources and Services Administration in 2016 show that at least 48% of children in the United States, so that's 35 million children, have had at least one adverse childhood experience, and more than 20% have had at least two. A score of 4 or more ACEs seems to be a remarkable threshold to inform alternative interventions. So thinking like disruptors, as we were challenged to do so this morning, how would our service delivery change if we knew the total ACEs experienced by the children on our caseloads? Could we track children and families into a different or more supportive service delivery course? All individuals experience stress, and in some situations, stress can be positive and tolerable. Maybe like right now for preparing for a presentation. This is opposed to the toxic or complex stress when a child experiences strong, frequent, and/or prolonged adversity. According to my current personal hero, Dr. Nadine Burke-Harris, this prolonged activation of the stress response system can disrupt the development of the brain architecture and other organ systems. And when we are in the business of promoting brain development through the use of hearing technologies such as cochlear implants, it matters if the child we're serving is experiencing this toxic, persistent stress. Adversity and associated trauma interferes with child development in several ways. Adversity limits brain volume and impacts executive function, self-regulation, attention, and information processing. Toxic stress can result in changes in the hippocampus, the prefrontal cortex, and the amygdala. And preschool-age children who have experienced 2 or more ACEs are more than 4 times as likely to have trouble calming themselves, are easily distractible, and have a harder time making and keeping friendships. For an excellent description of the impact of toxic stress on the brain and other systems, I refer you to specifically chapters 4 and 5 in Dr. Burke-Harris's The Deepest Well, and to the many resources available at the Center for the Developing Child at Harvard University. They have great videos, briefs, and downloadables on the impact of toxic stress. An additional important factor for us to consider is the intergenerational nature of adverse childhood experiences. For caregivers who are also experiencing adversity, the symptoms may be intensified. In fact, the child, him or herself, may be an emotional trigger for a parent who is overwhelmed and unable to respond in a caring way. Daily routines may become more difficult and conflicts between parents may develop. So, while auditory verbal practitioners are not expected alone to solve, manage, or treat problems related to adversity, they're important members of teams who can assist families in increasing access to resources to reduce the harm caused by adverse childhood experiences. Some of us may feel that this is beyond our scope of practice, but by encouraging, supporting, and facilitating relationships and attachment, practitioners can help caregivers buffer their children from the damaging effects of adversity. Because our work with young children and their families actively engages caregivers and is often home or routines-based, these efforts can be embedded in our interventions and will enhance positive outcomes across multiple domains. We ought to also consider the ways our systems of service delivery may inadvertently add barriers and burdens to families. For example, fixed scheduling of session times may create a hardship for working caregivers or those with limited access to transportation. With attention to both the individual qualities of the professionals and the systemic factors, practitioners can provide substantial support to children and their families. Promoting resilience might involve bolstering individual interactions, and it might mean changing a rule, a policy, or a practice in our clinics and schools to be more inclusive. So, despite adversity, many children and families are able to flourish, and resilience is defined as the ability to cope with the stress caused by challenging situations and is understood at both the child and the family level. Acknowledging families' strengths and achievements are crucial first steps in implementing this two-generation approach that supports child and caregivers. The best formula for success focuses on helping caregivers develop a parenting style that is both warm and nurturing while providing consistent expectations and consequences. So why aren't we doing better at this? Why haven't we figured this out by now? A survey Susan Lenehan and I conducted indicates that professional preparation neglects to equip practitioners with the knowledge and skills needed to respond effectively and confidently to such adversity. So consider your own graduate education. Did your professional preparation program prepare you to serve patients, clients, learners who experience great adversity? We surveyed early hearing detection and intervention practitioners, asking them to rate the extent to which their professional preparation programs address challenges encountered by children and families living in poverty, so one aspect of adversity. The two highest rated challenges, this is a little hard to see on this small slide, included access to hearing technologies and a lack of enriching environments, so those were addressed to some extent. Further, more than 80% of the respondents indicated that the challenges associated with lack of transportation, housing insecurity, and food insecurity were infrequently or never addressed in their preparation programs. We have plenty of room for improvement in both our pre-professional preparation and through in-service and continuing education offerings, like we're doing today. So a focus on resilience, in addition to identifying services that support individual children and families, must also include an opportunity to advocate for both systems improvement and policy change. The use of restorative and interprofessional practices seem to be very necessary ingredients to compensate for our lack of preparation and our individual capacity to support families through significant adversity. In the spirit of resilience, we look to those restorative practices that can repair, heal, and support positive outcomes. So given today's time constraints, I would encourage you to check out our framework of effective practices that professionals can use to foster resilience for children and families, and that's published on, in an issues brief on the NCHAM website. You'll see integration of interprofessional and restorative practice in that framework. By working together as a community of learners who create interprofessional partnerships, professionals can maximize their collective knowledge and skills to best support children and families experiencing adversity. Thank you.
Thank you, Dr. Voss. Our next speaker is Bruna Youssef, and her presentation is Parents' Engagement in a Cochlear Implant Orientation Program.
Hello, good morning. My name is Bruna Capalbo. I'm from São Paulo, Brazil, and I'll present my work named Parents' Engagement in a Cochlear Implant Orientation Program. It's like this. Hi, Sad, I'm from Brazil. This is my country. We are the biggest country in South America. I live in this green yellow area in the southwest region in São Paulo, state of São Paulo. This is our flag in our public health service named SUS. 9.7 million of Brazilians have some disabilities. Every 10 baby borns, 3 having hearing losses and 1 in severe. To 2000 through 2016, we made more than 7,000 cochlear implant surgeries in Brazil, and more than 4,000 was in children between 0 to 12 years old. My presentation goal is to show how families' engagement was and to explore the reasons of attendance and lack of it. So we are Hearing Institute, in Portuguese, Instituto Escuta. We are a multidisciplinary team. We have 2 big projects. The first one is the Open Hearing Project, so all families with any kinds of disease of hearing losses can come to our service and have a conversation to our professionals that are speech therapists, that I am, psychologists, and a social worker. And I will tell more about our second project, our intervention program, that is a weekly multidisciplinary project, so families spend with us once a week, 2.5 hours, and is a project for the family, so parents and children has to spend with us these hours once a week. How I said, we are a multidisciplinary team, and we made activities designed especially for the parents, children, sometimes separate, sometimes together. To enter in this process, the family has to pass through evaluation process. There are 3 or 4 visits. They come to our service and make tests with the specialist. So, like me, I'm speech therapist, so we made some tests to see how is the language development of the children. After this step, the family has to sign a contract with our social worker to amount has the responsibilities for the families, for the institute, and how much money they will spend with us. So this project is paid, but families pay how they can. So we have families that pay 20 reais, it's like $5. After this process of evaluation, the family can begin in our weekly program. But our groups are closed, so families only can enter in our project in February or August after our winter break. In July, our winter break, our social worker made some home visits in each family's homes to see the vulnerability area, how families works, how is their lives. Our method was to collect and analyze information about families' attendance and evasion from February through December of 2018. In this period, we had 27 families divided in 2 groups. The first group was the families that finished the process of evaluation, that we have 16. The second one was the families that did not finish this process for any reasons, that was 11. In the first group, 12 families stand with us all the year, and the second group, only 2 families spend with us all the year. It's a big difference. We had in December 14 families divided in 3 groups. In the first group, we have a average of attendance of 69%, the second one of 75%, and the third one of 79%. We have a mean of attendance during the year of 74%, almost 75, sorry. After seeing these numbers, we made some actions. The first short-term action that we made, that all families had to finish the process of evaluation for beginning in our intervention program. We made some long-term actions too. The first one was bigger groups. So last year, we having 14 families divided in 3 groups. One group with only 4 families. It's a little big number. If two families didn't come to our service, we couldn't do the activities that we desired for the families because we don't have people enough. So in this year, we have 17 families divided in 2 groups. So we have more activities, more families, and more empowered the families are. We felt the families were not that engaged in our project too. So in this year, we promote some workshops to them, teachers and other families, something like make soaps, make cakes, and we felt them more closer to our service too. We have unexpected results too of our home visits. We found a strong impact in low-income families. So families, after the home visit of our social worker, were more empowered and more closer to our service. Now I'm gonna share with you a study case, a Jay case. Jay is a boy of 6 years old. He has unilateral cochlear implant and he uses sign language. His mom had a little support from his biological father. They both live in Northwest region. She came to São Paulo, left him with his grandmother, but they now both live in São Paulo, and she has a new partner. She had many difficulties to engage in playing, and she tended to delegate the development of Jay through the professionals. She came to our service because she was a good mom to take care of him, but she was not one helping him talking. She heard this from a professional in a science center of São Paulo. In the first semester, she had adherence of 50% in our activities. After the home visit of our social worker, in the second semester, she had adherence of 89%. It's a big difference. We found the mommy closer to our service too. She shared her struggle. She was more powered. She can do with the Jay's deafness, with like special school, with the family. She was more empowered of her life. She stayed with us all the 2018 year, and she's still with us in this year too. Well, why we can conclude after seeing this number and after seeing this whole things, the first conclusion that to finish the process of evaluation is a major factor from families' accessibility in accession. The second one is of 50% then reach us in our open hearing project can actually keep the activities that we offer because of many problems, many social problems of Brazil, like distance, money issues regarding transportation, and families, parents commitment, all kinds. For the 14 families that stay with us, all the 2018, of 18 year, we consider a good engagement of 74% because we are a weekly program and the family has to spend with us 2.5 hours in a weekly, so it's a big deal. The fourth one, for families with low incomes, we found out that the home visit of our social worker noticeable a good impact on accession, and individual strategies need to be taught to each family's needs. So we are a group program, but we have to think and believe each family's needs. That's it. Thank you. This is my email, and this is our page in Facebook, Instagram. If you want to follow us and see which activities we made, that's it. Thank you.
Our next presenter is Dr. Teresa Caraway, and she'll be presenting on getting the word out, raising awareness of opportunities for today's children with hearing loss. Teresa.
Thank you very much. Thank you, Dr. Yvette. This is wonderful that you've put all this work to gather us together for this conference, so appreciate your work. I know it's a labor of love to birth this. You know, it's one of those things, we walk in the room, this is my most favorite conference, and I love it because I walk in and I say, yes, these are my people. And the problem is, yes, we are the people. And do people outside of this conference really understand the importance of childhood hearing to all child development, the importance and the opportunities that we have today with today's technology? So we have this amazing opportunity of how are we going to get the word out? And do I just do this green button? All right. Here are my disclosures, and I am compensated as CEO of Hearing First, and you can see my other disclosures. But cochlear implants and the probable listening and spoken language outcomes, unfortunately, remain one of the best kept secrets. And so we have to look at, here we are in this world of contemporary cutting-edge hearing technology, and yet we still aren't embracing all of the tools that we have available to us to get the word out. And the reality is, it's not how it used to be. And so we have to be looking at who are the end users, who are the people we're trying to reach, and that would be the parents. The parents are the ones who need to be empowered, they need to be equipped, and they need to have current and accurate information so that they can make decisions what's best for their families. But so then that begs the question, where do families hang out these days and get their information? And so that means that we have to look at the digital habits of families. And the first thing we have to realize is that when I was having my babies, digital opportunities to connect did not exist. And so one of the things we know is that families today are always on, and that millennial moms particularly spend a significant amount of time on different media, and not just online, but across all channels. And in fact, most millennial parents are now going to advice online instead of asking friends and family. It's kind of their first source of where they are seeking information. We know that 85% of millennial parents, and I think that number is even climbing, are using social media. We know that parents today, 81% take photos and videos of their child daily and share them. That's a whole new habit than what I was used to, and maybe what some of you might be used to. But the other thing that's happening is that exponentially, year after year, we see a growth in how parents are seeking information from parenting and family-related apps. The other thing is that not only are they very social, but they turn to lots of video. And they spend a lot of time getting their parenting advice from video content. And in fact, one of the biggest changes has been in millennial dads now that we're seeing how they're accessing parenting topics, and 86% of them are accessing YouTube for guidance on key parenting topics. So Facebook, YouTube, and Instagram are some of the most popular social media sites among millennial parents. And we know that most YouTube and Instagram users are between the ages of 16 to 24. And that is also a demographic that is having the babies today. So we have these ready-made tools. So the question becomes, can we design a comprehensive digital ecosystem that can support families in reaching their desired outcomes, and can we support the professionals that serve them by raising awareness, by providing education, and providing online communities and improved child practices and child outcomes. So we, at Hearing First, we created a digital strategy that's a comprehensive digital ecosystem that is compromised. It began with a website. It then looked at and wove together all of the different platforms and ways that we could use so that we could push quality content information out as well as then pull in. And so what I'd like to do is I'd like to really concentrate on phase one. We knew that first we had to establish a website and establish good quality content. And that's the key there, is that when you look at many of our websites and things that are out there, they were written more for professionals by professionals. And so we need to make sure that we're meeting the end user needs and what parents are looking for and what they're seeking. So, and then phase three was learning adding the learning experiences, and phase two was learning the professional community and support. So I'm really going to talk about phase one in terms of what those results are. So can you build a new website? And part of this is you can't just set a website out and say, build it and they will come. You have to have a strategy of how you're going to reach those millennial families where they hang out. So here you'll see over time how the page views have grown as we were established in October of 2015. You can see how it has steadily climbed. Our number of unique users to our site last year in 2018 has now grown to 74,000. And one of the things that we're really excited to see in terms of our analytics is that even though as our numbers grew, our time on the site has still remained strong and in terms of quality standards, a good length of time. We know that from in 2018, for example, that 73% are new visitors to the site, 82% are female, and 53% of our visitors are between the ages of 25 and 44. Again, the demographic that we're wanting to hit, that know the status of your baby's hearing first, because all child development hinges on it, and follow up on your newborn hearing screening, and then the listening and spoken language opportunities today. Here you can see some of the results and where we are today as of June 30th in terms of our social following. We know that we have 41,000 plus followers on our Facebook page. We know that 83% of them are women. We know that we've also conducted Facebook Lives because, you kind of have to understand and learn the algorithms that different platforms utilize so that your posts can show up on feeds where you want them to show up. And so we conducted Facebook Live Ask Me Anythings, and we did 10 of those, and we know that we've reached 74,976 unique users. On Twitter, that's more for professionals. Facebook, we have more parents there. Twitter is more professional followers. And then Instagram is one that we will be developing our strategy more because we know that particularly for Latino families, Hispanic families, that is a really strong platform because it's more visual. So we'll be developing and we know we want more followers there, of course. So the other thing is that we've been looking at our YouTube channel and building that. You'll find there many videos that we are accumulating, like Did You Know videos and tips and tricks that for you to utilize and to enhance your practice with families. One of the things I want to call attention to is that we launched a microsite called lsllife.com. That's with 2 L's. It is a storytelling platform where we're sharing stories of families who chose listening and spoken language and sharing their journey. It is a terrific site for you to refer your families to. If they'd like to see and other families how it's all turned out, I encourage you to check it out. We have 6 family stories on there now with the augmented videos. We have 3 that'll be coming out at the end of July. I also encourage you, again, we're trying to develop multimedia to have more reach, and so we do have a podcast that we have piloted. It is dealing with the first year following diagnosis and with the diagnosis, opportunities, and outcomes, and there's 6 families that are interviewed in that. Again, we have had 3,435 listens to the episode, to the season. And it is another great resource to enhance your practice to support families who are wanting to connect and hear from other families. Newsletter, we have white papers, we have our resources, we have over 40,000 downloadable resources, people who have downloaded our resources now, and that continues to grow. And if you'd like to know more about the Phase 2 education, Wendy DeMoss, Programs Officer, will be presenting Friday about the learning experiences and the education results. And then on Thursday, Marge Edwards will be conducting about the communities. So in conclusion, a comprehensive digital ecosystem does and can meet the needs of parents and can provide significant information of what they're looking for. The most important thing is simple and clear communication is critical, and to deliver the right message at the right time. So I hope you'll join us. If you're active on social media, share posts, refer families to the family-to-family support community, engage in our professional learning community, help us along the way. It's our, so that together we can get word out, raise awareness about this amazing opportunity for children today. So thank you.
We have two presenters for the next presentation, Dr. Maria Leno and Dr. Laura Rickey, and the topic is cochlear implants and lack of follow-up and ethical dilemma.
Okay, thank you. So my name is Maria Leno, and this is Laura Rickey. So we're here to talk about pediatric recipients who are otherwise typically developing, whose parents have chosen the spoken and listening approach as the outcome, but are not following through with appointments and recommendations, and what we can do to help with this.
Right. So most of us are familiar with the FDA candidacy criteria. And again, we're focusing today on CI recipients who are otherwise typically developing, but I want to highlight part of the FDA candidacy criteria is realistic expectations and commitment to follow-up appointments. And I think that's something we don't think about as much, but for our presentation, a very important part of candidacy.
So obviously, once a child's identified in the cochlear implant range, the family needs to make the decision about the child's communication needs. A method of the communication is a very personal decision. We know that families need to be informed of all their options, listening to spoken language, cued speech, American Sign Language, and total communication, and that this information should be given in an unbiased manner. So again, we need to go over the realistic expectations and understand the outcomes that the parents need to comply with after they choose their method. So if they choose listening and spoken language with a cochlear implant, these are the expectations we have for them. First, they need to complete a 3 to 6 month hearing aid trial, which that includes an appointment for a hearing aid evaluation, an appointment for a hearing aid fitting, hearing aid checks during that trial, and then also ear mold impressions during that time. So they're already coming quite a few times then. They need to show up for a cochlear implant evaluation and a speech evaluation where they need to remember to bring the hearing aids, and if not, be rescheduled. They come for a physician evaluation and a pre-surgical visit, and then finally surgery. After the surgery, because we all know it doesn't end there, they need to come back for a post-op visit with the otolaryngologist, an initial activation with the audiologist, 1 to 2 week activation appointments, 1 month activations, minimally every 3 months if they're doing well, and then also come for AVT weekly or biweekly. So we expect that the families can come to all these appointments, wear their device all waking hours, practice Ling 6 sounds, practice the AVT at home, work through their progressive programming, all while also dealing with the rest of their life.
So what happens if our families are non-compliant with these recommendations? So they're not coming to those appointments and there is lack of device use consistently. Could we consider this lack of device use and not coming a problem that we should involve social work or other specialties at the time? And if so, when do we make that choice? So this isn't new news, we know. No-show or canceled appointments and low wear time is going to equal poor performance and possibly no true language. We reviewed cases of typically developing pediatric CI recipients whose families elected listening and spoken language as the outcome. And in our review, we did find patients who are non-compliant with device use that has led to poor, if any, language development. These families did voice understanding of the follow-up involved for the child, and we know this isn't new news, but what do we do when we're seeing this and we're trying to solve this problem?
So first we have to consider the barriers. There's obviously several factors that contribute to a lack of follow-up on the family's behalf. It can be a lack of understanding the need for therapy, the need for programming, and the need for consistent use of devices. It can also be a lack of local resources available to the families. Are they traveling 1 hour to 2 hours to get to your clinic? What about accessibility to follow-up? Do they have reliable transportation? Are they taking time off work? Do they have the financial resources to pay for parking, for gas, to get to your clinic, meals while they're there for long hours? There's also family chaos and disorganization, lack of trust in healthcare providers, impairment of the caregiver's belief system, all of those. Are we even on the same page as the family? And then the child's attitude and behavior, we know they don't want to always keep it on their ears. and also variable caregivers. Are they coming to appointments with the stepfather, the aunt, the grandmother? Are they under the care of different people every day?
So the first step would be to address barriers. This would include reevaluating the goals. Do they still want listening and spoken language as their outcome? The second is to address the barriers. So we can address them, and one of our presenters earlier talked about our training and addressing those barriers. So we have so much training, but there's a time and a place where we might need social work to get involved to help with things like transportation, or getting time off work, or care for their other children while they're at appointments. So we need to discuss those barriers with the family and try to come to a resolution how we can resolve those. And that involves getting those appropriate professionals. And again, we want to discuss the importance of follow-up and make sure that we all understand how important it is and what we need to get to the outcome that they have chosen. So after taking a brief survey of colleagues across the country about what they do in this particular situation, it seems there's different avenues that centers are taking. These have ranged from no action being taken at all, dismissal following 3 no-shows, to involvement of social work and opening county children's services cases.
So at this point, it's been a reoccurring event with these families. We understand this isn't for all families, but there are some times where this happens. So this isn't the only time these families have no-showed. For many of us, mapping and AVT appointments are long appointments. So there's slots that could be filled with families who want to come or need to come, but they're left open when these families don't come. So ideally, we don't want to turn a child away for any reason, but now they're taking time away from families that are compliant. So this can affect productivity, which for any job reflects value, and we need to be aware of that. So the question is, what do we do?
So let's review. At this point, the family we know has chosen cochlear implants. They've chosen spoken language as the outcome. We think we've addressed all the barriers, and the family continues not to follow up. We're kind of at our limits of what we feel we can do for this family. So this is when we start to ask, could this be considered a form of neglect? So neglect is frequently defined as the failure of a parent or other persons with responsibility of a child to provide needed food, clothing, shelter, medical care, or supervision to a degree that the child's health, safety, and well-being are threatened with harm. Medical neglect is a subcategory of neglect, and it specifically includes failure to heed obvious signs of serious illness or failure to follow physician's instructions once medical advice has been sought. Either of these situations can be fatal in some cases or can lead to chronic disability.
There's several factors that are considered necessary for the diagnosis of medical neglect. So if we take a look at these factors and apply them to this patient population, and again, we're talking about patients who have chosen spoken and listening language as an outcome. If they've chosen another mean of communication like sign language and are successful with it, this doesn't apply. But for our families, the child is harmed or at risk of harm because of lack of health care. There's no true way for a parent to explain dangerous situations to the child that could lead to harm. The recommended health care offers significant net benefit to the child. We believe that language is a significant net benefit. We use it every day, and we need it to be successful and independent in life. The anticipated benefit of the treatment is significantly greater than morbidity, so that reasonable caregivers would choose treatment over non-treatment. Again, this was a choice that the parent made. It can be demonstrated that access to healthcare is available and not used. We've addressed the barriers. They're still not showing for appointments. The caregiver understands the medical advice given. Again, they've either vocalized or have signed written consents or expressed their needs and wants for their child.
So based on the definition, it's in our opinion that non-compliance with device use after addressing all these barriers and doing everything we can could be considered medical neglect. With little or no language, these children could fall behind their hearing peers in communication, cognition, reading, and social emotional development. This could put the children at risk for lower education and employment opportunities. We believe it certainly could be considered medical neglect.
So after a review of our population, we found that patients that had around or greater than 40% no-show rate and had low wear time developed poor, if any, expressive and receptive language skills. So our proposal would be that after multiple no-shows or cancellations and lack of progress, which our center is considering 3 no-shows as a red flag to take action, we want to first call social work and discover the barriers and address those barriers. Then if this continues, we would suggest reporting medical neglect to County of Children's Services and maintain an open line of communication so that we know exactly when the case is open and closed and see what changes during that time with the family. This is the ethical dilemma. Obviously, it's a scary thing to open a case of medical neglect, but we don't want to push families away. And in our experience calling, that we've had some questions of consideration from the caseworkers because it's an invisible. It's something they don't see. They don't see broken bones. They don't see the child's not being fed. It's just that they can't develop language. And again, our point is that this is a significant benefit for the child.
So for future research, because we did a brief survey of colleagues across the country, and it seems there's many different methods to dealing with this situation, we would like to manage our situation closer and watch what happens if we were to open county case of cases with the county. And we'd like to do a survey to see what other centers are doing across the country when this particular situation comes up. All right. And that's it.
Okay, well, thanks for that great presentation. I promise probably many of you want to comment and add information. As me as a psychologist, I'm dying to ask some questions, but we promise there will be time for a panel discussion and open conversation about all the amazing talks, but we want to keep us on track. So our next presenter is Dr. Joni Alberg, and she'll be talking about family input to program development and improvement. Joni.
It's great to be here and to see so many of you out here today. It's the red, it's the green button. Okay. What I'm going to be sharing today is work that we have been doing at Duke University Medical Center to build a pediatric cochlear implant program. Specifically, how we're engaging parents as part of our team in the development process, development, improvement, ongoing evaluation, the whole gamut. And what we determined very early is that parents must be part of our partners in our team and partners in our care. And I think that's kind of follows nicely with some of the comments that we've just heard from the speakers who went before me. So I want to just tell you a little bit about what's happening at Duke, because you may not already know this, but in 2017, Duke was very fortunate to welcome Dr. Howard Francis as the chief of what is now the Department of Head and Neck Surgery and Communication Sciences. That's just as of July 1st, was a division prior to then. And Dr. Francis came to us from Johns Hopkins, where he'd had 25 years of pediatric cochlear implant experience. And that was part of the reason that Duke was so interested in bringing him in, is because although Duke had a well-established adult cochlear implant program and had been providing the evaluations and diagnosis for pediatric hearing loss, they didn't have a cochlear implant program that was a comprehensive, unified, in fact, did very few cochlear implants. And so with Dr. Francis's arrival, Duke's desire to move forward into this realm, they commissioned a strategic plan, and that's where I came in. I don't actually work for Duke, but I'm a consultant, have been working with them since the summer of 2017 to help with this process. And it's evolving, and I'm going to tell you a little bit more about that. The other thing that when we were doing this, we wanted to take into consideration, was really important, was to look at service and outcome disparities among our families and to look at what we could maybe do to address those. That was a big part of what we were looking at. Also, making sure that we were able to hopefully look at coverage of providers and services across our state. North Carolina, like so many of your states, is large, has a lot of rural communities, and we know that families live all across that. And how could we possibly engage community providers to help us with what we're trying to do? That's not just in early intervention, early years, but through the school years as well. And we also were very concerned about the disparities that we observed among families of varying socioeconomic status. And so we really wanted to keep all of that in mind. So we started out with an internal and an external landscape analysis, and and our goal was to answer two questions. What barriers exist to the successful outcomes of children who receive cochlear implants in North Carolina? And then what could Duke do? We knew that 8 miles down the road, we had an amazing program, well-established, long-time leader in pediatric cochlear implants in the University of North Carolina. Their team has done some cutting edge and has been leaders in this field for a long time. So we weren't trying to say, let's try to do what they're doing. It was say, what could we do that maybe is different, that's maybe could meet needs that aren't already being met? So those are the questions that we set out to ask. We are fortunate in North Carolina. We have a lot of people involved with children who are deaf or hard of hearing, and so we spent 2 months conducting focus groups and individual interviews with this array of people. We have an early intervention program in North Carolina that is statewide. Teachers of the Deaf. There are 28 teachers across the state who do nothing but provide early intervention services. Some of them have listening and spoken language credentials. Others, all the others have had training in listening and spoken language, since that's the primary or the most desired choice for parents in North Carolina. And then we had a lot of other groups that we brought together, including, as you see at the top, parents who I knew from, or these groups had knew and referred to us. So we gathered information from as many people as we could about the state of North Carolina. So what we learned, and this has been mentioned in a couple of other comments, but the biggest barrier, the number one that we found, was that the time that it takes a family to travel to a cochlear implant center can be a huge barrier for them. Time off of work, the cost associated with that, families who don't, if they don't work, they don't get paid. So we suspected that was going to be a big issue, but we found that it really was. We also found that if we could address a community-focused the community-focused nature of a program, that if we could somehow influence and expand or extend what we could do from a center point, the point of a center out into the community, that would be something that would really meet the needs of so many families we weren't able to do at that when we first were looking at this. And then the other thing that was really critical for us is that parent input, we knew, was a very critical piece of what we needed to be doing. So quickly move on. This slide, whoops, going back, just to say one of the things we did early on too, because we were building a program, was we made sure that we brought our big team together, which included administrators and from both the clinical side and the hospital side, because we knew that expanding a program would probably mean needing some funding to do some things, which was a very smart, good thing for us, because they bought into what we were trying to do from the very beginning. So one of the things that we decided was we had to have a parent advisory panel, and we set out to select parents to serve with us, to come and be a part of our team. And this was, I have to give the Duke team a lot of credit. This was in essence, it was going to be an evaluation of the team, and our team, our audiologists, speech pathologists, our otologists, were ready for that and said, no, we need to know. We want to know what we can do to better meet the needs of the families who need our services. And so I think that's kind of brave, because sometimes, we wanted to hear the good, the bad, and the ugly, and sometimes that is not easy for, I know it's not easy for me sometimes to hear that, but, and it's true for all of us, I think. So I want to recognize that was a huge piece and a huge reason that this has been such a successful process for us. So we looked for parents that had 3 different criteria. We wanted parents who were currently receiving services at Duke. We wanted parents who had been at Duke but had left and gone somewhere else down the road, 8 miles, because we wanted to find out, okay, what drove them away? We knew that had happened, but we didn't necessarily know why. And we wanted to talk to parents who had gotten services outside of our state, who maybe came from somewhere else. So those were what we were looking for. We found 10 families. I'm going to talk really fast because I know my time is going. We had 10 families that we reached out to, 5 of whom said they could participate. And we had 2 receiving services, 2 who had been at Duke, and 1 who had been, her children had been identified in Texas, and she had received services, they had received services at Sunshine Cottage. We started out with a questionnaire that we asked each of them to complete in advance. It was written. There were 5 questions, Likert scale, extremely satisfied to extremely dissatisfied. And then we had opportunity for specific written feedback, and every single one of the parents provided very detailed and specific written feedback, which we were thrilled to get. We followed this with this was kind of and this presentation is on the website for the conference, so I'm going to skip through some of these slides. But what we found after we did that, we wanted to bring them together. We wanted to dig deeper into their comments and find out even more about what they were, what they could tell us. And we had a face-to-face meeting. 2 parents came in conference call, 3 joined us in person. They came from a 100-mile radius on their own time, on their own money, which I'll tell you is a little bit of a limitation. We had our our clinical director for pediatric audiology, our director of speech and language. I was there, and the chief of head and neck surgery, Dr. Francis, was there, originally thinking he would come for the first part, greet, welcome. He stayed for the entire meeting. It was that kind of a meeting. The parents opened up and shared just out of their hearts, their true feelings. It was so phenomenal, and we were so fortunate that this group of parents was so willing. And I think part of it is that we asked them, would you tell us what you think? And some of them said, no one's really ever asked us that before. No one's really wanted to hear what we had to say. So I think that was a huge part of it as well. So they told us a lot of things. We immediately took that list back to our team and said, this is what we've learned. What are we going to do about it? So we started doing things. One of them, that I'm sure many of you deal with is it's a crowded clinic with lots of noise and there's not a lot of space. What could we do to make it better and more family friendly? So, even things like putting bassinets in the rooms where we consulted with parents so they could put the baby down was sort of a simple solution, but we never thought about it. So we've put in dimmable lights. There's been painting that's been done to change the colors. So we're trying to do some sort of simple things, but things that mean a lot to the families. We shared this with them. They told us a lot of things we've addressed. One of the big things is we have a patient navigator that just joined our team in March. She is the point of contact for all of our families going through. We're hoping that this is, and our intention is that this is going to reduce a lot of miscommunication and misinformation and confusion on the part of our parents. And it's already, we're already seeing such positive results from that. Some more of that. We shared this in writing with the parent panel. We said, here's what we did it like this. You told us, here's what we've done. Here's what we're doing. We haven't addressed this, but we're going to. And we've done that twice now since they came. I want to share the limitations to this, and then I'm going to close. These were all moms. They had the ability to participate, and it was not a very diverse group in terms of socioeconomic status. What we did find out is that there are barriers, and access to audiological and listening spoken language services where families live is a very important component, and in fact that has become a very major focus of what we're doing with the program we're building at Duke. And we also recognize that we have to have parent input throughout the process. So our focus now is on increasing community capacity beyond the Cochlear Implant Center and actually building it out in the communities where our families live. We're picking new advisory panel now members. We're going to continue this. This will be an ongoing part of our program, and we are going to be addressing with this next panel some of the diversity that we didn't have in the first panel. We're going to be be doing even more follow-up in-person interviews one-on-one with our families, but we're integrating that parent evaluation feedback throughout everything that we're doing at Duke. Thank you so much. There's my information. Sorry I ran over.
Our next presentation is by Dr. Britton Barker, exploring the identities of hearing parents who choose cochlear implantation for their children with hearing loss.
Hi, I am Dr. Britton Barker from the University of Iowa. I'm sorry, I'm not. I graduated from the University of Iowa. It's already been a long morning, evidently. And I love all of the team at University of Iowa, but I also love my team at Utah State University, where I am currently now. This is terribly embarrassing. And today I wanted to talk to you about something a little different from what I'm traditionally used to talking about. This is a new project where I've started to explore parent stories using qualitative research designs. This is different from my experimental designs that I've used in the past. The reason that I've headed in this direction is because I've quickly learned, like many of us today and listening to this panel, that in order to be able to move our care forward, we have to have opportunities to understand where the families are coming from and how we can serve them from a patient-centered perspective. The only way we can do that is by employing qualitative studies outside of things such as word rec in a sound booth. To do this, I started a collaboration with my colleague Christina Sharp, who is now at the University of Washington, and also an AUD student of mine, Kelsey Chandler. I wanted to let you all know that we have no disclosures, and at this point, I wanted to go ahead and share with you a little bit of background. As most of you know, more than 90% of the children with hearing loss are born to parents with typical hearing. These children oftentimes do not benefit or access audibility from hearing aids, and thus these families make a choice to pursue cochlear implantation. Cochlear implantation, however, and this choice to pursue cochlear implantation can be a complex and stress-inducing event. This can also cause a lot of trauma in the family, much similar to other contexts in which there's been a big event, stressful and otherwise. For these parents, when they are making these decisions, not only are they making decisions about pursuing cochlear implantation, they're also making decisions about pursuing different educational perspectives, different modes of communication, as well as listening intervention and therapy. When this is happening, as a result, the parents' identities are shifting. The expectations that the parents had for their children prior to the child's birth, these pre-baby or pre-hearing loss expectations, have caused a big shift in their identities. These identities are often constructed in ways that we might not recognize as care providers. One way that we as human beings are constructing our identities on a daily basis is through the stories that we're telling. The stories that we're telling to ourselves and the stories that we're telling to those around us. This is known as narrative sense-making in the field of communication studies. Narrative sense-making and looking closer at the stories that people are telling, in this case, the parents of children with cochlear implants, can give us insights into what the parents are feeling and how they are managing the stress that comes with the identification of hearing loss and the decision to pursue cochlear implantation. If we look more closely at the stories that parents are telling us, this could provide us with important information and particular therapeutic targets where we can help the families and the parents and ideally result in long-term positive effects on the pediatric cochlear implant recipient's holistic development. Thus, for this study, we used a qualitative approach and we framed it in an interpretive narrative approach. So there are many ways to study narratives, and this way of studying narratives takes an ontological approach and looks at the changes over time in a person's character and self-identity. This is very different from pursuing a story as the end-all, be-all concept of that person at the time. So when we look at stories from this perspective, we need to realize that parents can create, repair, or even destroy their identities while negotiating personal agency through telling their stories. Thus, the story becomes a very important tool for us to better understand the parent's experiences and quite possibly gain an understanding of the potential impact of the parent's experiences on the child's successes or challenges with the cochlear implant. So our research study for this question was as follows. What types of identities do hearing parents construct when telling stories about their children's hearing loss and identification and CI intervention? So for these methods, we gathered stories from 20 different parents across the United States, from Utah to Southern California to North Carolina and right here in Florida. And these parents varied in their gender, their ethnic backgrounds, and also their socioeconomic status. From these stories, we then conducted thematic narrative analysis in which we aimed to figure out identities for each and every parent. We also engaged in validity measures and engaged in the verification procedures that are listed on the slide within. Now I wanted to go ahead and share with you our findings. In particular, I want to share with you the identities of the parents, and also I'd like to share with you some exemplars from these parents' stories. It's our hope that by understanding parents' identities, we can better shape the care provision that we provide to these families. By having a more patient-centered approach, we subsequently can have better outcomes for these children with cochlear implants. So 4 identities emerged from the parent stories: the proactive parent, the resilient parent, the vulnerable parent, and the detached parent. I'll go ahead and go through these at this time. So the proactive parent immediately jumped into action when they learned about their child's hearing loss diagnosis. These parents, oftentimes in clinic, we would refer to them as binder parents. They come in with the 3-ring binder filled with information, ready to share with you and share with others. These parents asked lots of questions. They engaged in independent research. One of these parents even immediately enrolled in a college-level sign language class for their child. Here is an example from one of our parents. We called everyone. We just saw the benefit of giving Drew the option to hear, and we knew that with the right support and intervention and early implantation, we just had a feeling that Drew would be okay with cochlear implants, and we wanted him to be mainstreamed, and he's living in a hearing world, in a hearing family, and we figured we would support him in any way we wanted to go when he got older. But for now, we're just giving him the best option. We've been learning all kinds of strategies before he turned 1, from early intervention about things that we were already practicing and putting into our routine. As far as bombarding him with language and narrating our day and all these things that we were already practicing, so when he was implanted, we already had these strategies in place. Alternatively, we also found the resilient parents. These are different from the proactive parents in the sense that when diagnosis happened for their babies, they experienced great sadness and despair, to the point that it was debilitating for some. But quickly thereafter, the parents overcame these challenges and these emotions and started to move forward, accepting their child's hearing loss and making decisions about cochlear implantation. Here's an example from Kendall, mother of Alex. So far, he's done just fine, that route, CIs, but I can remember the sigh of relief last year when he started reading. That's when I really felt like he's gonna be okay. That's the point in time where I really thought, we got it there. I mean, it'll always be a mountain to climb, but I feel like that was the first time I felt like really we'd climbed the hardest part of the mountain and we're seeing some really nice views at that point. And Mom starts crying. Oops. Also, third, we had our vulnerable parents. These parents, from a clinical standpoint, are some of the most important, I believe, that we need to identify and bring forth additional services for. Calling in social workers or psychologists and engaging in proper counseling skills will be very important for ensuring success for these parents and their children. These vulnerable parents describe their experience with children's diagnosis and CI treatment as incredibly frustrating. They hit a number of emotional roadblocks, and this was very concerning given that they seem to lack a strong support system in their lives. So, I was 22 and had given birth to my son and was actually alone in the hospital. And they asked if they could take him to the nursery so I could sleep, and they did. And at about 4 in the morning, a young girl came in and shook me awake. She threw a pamphlet at me and said, "Your kid can't hear. You're going to have to see a pediatrician in the morning," which, needless to say, was fairly devastating to a young woman and her first child. Anticipating everything to be absolutely perfectly, to go perfectly. So I, of course, was like, what do you mean? What do you mean that he can't hear? We see it again in Sophie, as she talks about crying and feeling like this was all of her fault, and feeling very sad about the fact that her child won't be able to do things like other kids can do. Finally, notably and very interestingly, we also have the detached parent. These parents, when sharing their stories, describe their children's experience with relatively flat affect. These parents told stories almost as if they were reading from a bulleted list of events that had happened to someone else other than their family. Sadie was born. She was emergency C-section. They don't know why she was. When she came out, she was bleeding underneath her skin. She was life-flighted to the University Medical Center. She started having seizures along the way. She was given medicine for that. Later on, we learned that she had what's called thrombocytopenia, where her blood doesn't clot when it was supposed to. Before she could go home from the hospital, we did her hearing test like every normal child. Sadie failed twice or 3 times. The parents in the present study constructed 4 pervasive identity types. And it's important to know that these findings have valuable implications for a better understanding of the experience of parents raising pediatric CI users. Identifying and understanding these identities can help us move forward in our ability to provide care to the families and follow through with family-centered healthcare. Thank you.
Okay, and our last presenter for this morning is Dr. Elizabeth Adams-Costa. She'll be talking about parent-child interaction therapy, a parent coaching intervention, targeting language, behavior, and maternal sensitivity.
Thank you for the opportunity to be here today. I am from the River School in Washington, D.C., and I am a clinical psychologist. I have no disclosures. In terms of, as my fellow panelists have outlined today, as you know, parents are absolutely critical to the intervention process for children with cochlear implants. And ideally, that means that we're offering family-centered care. So family-centered care should include having parents identify their goals, maximizing their strengths, helping parents to establish a secure and warm relationship with their child, teach parents how to have an optimal language environment. But what we know, despite the fact that there's this immense amount of pressure on parents to be the language models for their children, to provide this intense amount of support, there's often disruptions in the parent-child dynamic after a diagnosis, and there's also very, very little research regarding the interventions that we are doing to support parents in providing the optimal systems. So when we think about how parents are important for the process, it goes beyond just language. In addition to optimal language stimulation, we also have identified in the research that parents are important because maternal sensitivity predicts language outcomes for children with CIs as strongly as age of implantation. We also know that behavior of the child, if you're an AVT or a speech path, you know, and I've heard from my colleagues, that sometimes your sessions are spent managing behavior. And so there's this bidirectional relationship between child language development and behavior, where delays in language can obviously cause behavior disruptions because it impacts attention and emotion regulation, and the child is frustrated. And at the same time, disruptions in behavior can make it so that the interventions that the children are being provided aren't as effective. And so parents are then tasked with also managing difficult behavior in their children. So basically what we're saying is, this sort of time-honored and unbelievably unfair assertion, as my mom says, it's always the mother's fault. And so if that's the lens that we're looking at through, we owe it to our families to think very critically and do a better job about what are the interventions that we're providing. There's a lot of parent coaching interventions out there, but are they systematic? When a parent goes from one parent coach to another, are they getting the same quality of intervention from one person to the next? So at our school, we provide an intervention called Parent-Child Interaction Therapy, or PCIT. And I should say that I did not make PCIT up. It is a well-established intervention in the field of psychology that has 30 years of research behind it. It is considered the gold standard intervention for children with externalizing behavior disorders. And not only that, but the researchers have found that there's an unbelievable overlap between the intervention that PCIT provides, where we teach parents how to play with their kids, how to talk to their kids, but also how to manage behavior. There's an unbelievable overlap between this and what we teach parents in child-directed interaction around language development, how to effectively develop language in their children. And so the PCIT researchers, some that I know, have looked at language development as a secondary result of PCIT. And they found in a randomized control trial, an RCT, they found that kids with MR and kids with language delays improved language outcomes as a result of this. So when we think about the fact that so many of our kids with cochlear implants are struggling with both behavior and language, and that there's multiple systems here, we should be thinking about the importance of this intervention impacting both of these things. So to give you a little context, PCIT is divided into two parts. The first is targeting it's CDI is what we call it, and it's teaching the parent how to effectively play with their child, talk to their child, have a warm and secure relationship. And PDI, the second part, is teaching strategies to manage difficult behavior. So the current study looked at PCIT as a psychosocial and behavior intervention for kids with hearing loss, but we focused specifically on three things. We wanted to see if PCIT has an impact on maternal sensitivity, if it has an impact on child language development, and if it has an impact on child behavior, because we really want to look at interventions that can hit multiple domains. We think about treating the whole child. So basically, the premise is that if a parent assumes a critical role in providing facilitative language techniques to the child in conjunction with strategies that stabilize behavior, language outcomes will improve. So our sample at River consisted of 15 children with hearing loss receiving PCIT, and 3 of these children had both parents in treatment. Yay, dads. And there was a subset of the treatment group where we had a matched control group also from River. So the other interventions that the kids were getting were exactly the same. The only difference in our matched control group was that these parents were getting PCIT. So PCIT is different than some other interventions for parents. Parents are actually put into a room, as you could see through this picture here. They're on the other side of a one-way mirror. The parents wear an earpiece, and they are live coached how to utilize these skills, because this is about affecting change in parents' behavior. And telling a parent what to do isn't the same as, it doesn't mean you tell them once and then they do it. PCIT also has a coding system to see, are the parents actually implementing the skills that we're teaching them? And what we find in our research is that this doesn't happen overnight. It takes several weeks for the parents to be able to use optimal language stimulation, to be able to manage behavior. And where the coach is out of the room. That's because it's empowering the parents to be front and center in the intervention, while that initially can be difficult for some parents, most parents by the third week are like, what's the range on this earpiece? Are you going to come do bedtime with me? So in terms of our demographics, and I'll, this will be posted so you guys can read more. Primary language in the family home was English for 10 families, but we had 5 families that use at least one other language in addition to English. All parent participants had at least some college education, with most completing an undergraduate degree, so it's skewed in that way. This table, which is difficult to see here, includes our demographic information collected on the child participants. The ages of the children range from 2 years, 5 months, to 5 years, 11 months, and 8 children were identified as a racial or ethnic minority group. So how did we measure the outcome? So child behavior was measured in 2 ways. The first was looking at parent report. They filled out a report on their child's behavior weekly, and we also videotaped and coded the sessions. So we looked at if a parent gave a command, did the child comply to the command or not? We calculated % compliance. We also measured maternal sensitivity and looked at language input for the parent using a system called DPICS. And then we took those videotapes and looked at the mean length of utterance for the children. So in terms of our results, the pre-treatment is in this orange and the post-treatment is in the green. What we see here is in terms of change in parent language input, where we measured the parent's optimal language input, which we refer to in PCAT as pride skills. You can see this dramatic change pre to post treatment, and that's where parents are using something that we call the do skills, which includes describing a child's behavior as a language input. So you're putting the nose on Mr. Potato Head, you're putting the hat on the Mr. Potato Head. You guys know that. Reflecting a child's language and using positive reinforcement. Telling a parent to use those skills and the parents actually using those skills takes practice and coding and specific feedback. And that's where we need to get systematic about our coaching. We also found a change in the don't skills, where we coach parents to move away from language input that we know doesn't help with language development for children. So questions that aren't necessary, commands, or negative talk, ineffective commands in particular. So when we see just some other results to highlight, parents also improved significantly their change in effective commands. How many of you are parents in the room? Okay, me too. So you know that if you're in a battle with your 4-year-old about putting on their shoes, it's stressful. Did you know that there's actually 8 ways that you can make a command more effective? And that if you make a command effective in your discourse with your child, there's a significant increase that they will comply. These are the types of evidence-based information that we should be providing to parents if we want to improve their behavior. So you can see that significant increase in effective commands and decrease in ineffective commands. Again, how does that actually translate to child compliance? This is looking at % compliance, a huge increase. If you've ever been in a battle about, put on your shoes, there's a difference between your child listening 25% of the time that you ask them and 90% of the time that you ask them. That feels really different. In terms of a change in child's characteristics, I just want to highlight that the parent report of their child's behavior, according to the ECB, was also significant, where we didn't see that from pre to post treatment in the control group. And in terms of language, so how is this actually impacting language? Non-parametric analysis revealed that the mean length of utterance for the treatment group was significantly improved, whereas for the control group, you didn't see as much of a growth there. The last thing I want to talk about is the maternal sensitivity. We used a system called Parcheesi. These are the aspects that are looked at there, and we had probably the most striking results here when it came to maternal sensitivity, where there was no changes noted in the control group. And that's because people do what they do, unless we are actually giving them information on how to turn it around. So in conclusion, we really need to have more clinical research focused on quality interventions for the parents in order to provide them with support. There's limitations to our study, but given the variability of outcomes, there's really a need to systematically evaluate approaches and to seriously consider looking at interventions that hit multiple systems of development. If you want to read more about our ongoing clinical research, you can check out our article that was published in the Journal of Language, Speech, and Hearing Services in Schools. And I thank you guys for your attention and time.
Okay, so we're going to switch to these mics. Anyone hear me? Now? Yep. Is this on? Yep, there we go. So we do have a few minutes for questions. So there are microphones around the room, so we encourage you guys to, if you have a question about any of our speakers. Yes.
Hi. Is this on? There we go. Hi, my name is Heather Grantham. I'm from Washington University in St. Louis. I have a question for Dr. Lino and colleague. You used a very eye-popping term, medical neglect. And it reminds me of a study by Tom Humphreys and colleagues from 2012 done in the, or I'm sorry, not a study, a commentary done in the Harm Reduction Journal that used a very similar term, except in reference to depriving children of American Sign Language input. So maybe that's a conversation for another day, but I wanted to let you know that it just really reminded me of the importance of terminology and the importance of words and how we use them. My question is, you talked about reducing barriers and trying to knock down barriers. You referenced a related service provider like a social worker. To what degree do you work with early interventionists, teachers of the deaf, and people within school systems to help reduce those barriers?
Yeah, the barriers could be helped by anybody, not just social work. Obviously, social work is a good resource to go to, but we have great early interventionists that we work with daily. We have great educational audiologists that we work with. We have a great school for the deaf. The point wasn't just go straight to social work, but use our other professional resources that we have available, and that we don't have to just limit ourselves to what we know, but to help start the conversation, that there's other people that are specialists in their area for a reason, and that they can help get to different points of those barriers and resolve them better.
And yeah, if we were to consider any reporting beyond, to county services or anything like that to talk about neglect, it's generally a group conversation between social work, our physicians, and ourselves to say, have we done everything we can? Is it time to take another step? And if so, what step could that be?
I actually have a comment about just that, just because I've been holding it in this whole entire time. So I think, part of this is how this meeting where we're talking about including other disciplines. And it feels very different when we include a social worker or a psychologist when a family's not following through or they're not doing well, versus including them from the beginning and having those conversations up front. So I think that's the take-home message that we're talking here, is that sometimes we could see a little bit of these red flags, but are we addressing it before we see that it's now impacting outcomes? We should be having these conversations up front. We should be, I think we all do counseling, but we can all get better at it, whether it's teachers of the deaf or early interventionists, but we all need to work together, as oftentimes we could see a little bit of these red flags, but we're not doing anything about it until we see a decline in some performance or attendance. So in our clinic, I think that's what we try and do, is if we see those up front while they're going through the CI processes, start addressing them then. Not to withhold them from getting a cochlear implant, because we know that's equally as important to have early implantation, but start addressing that. Start involving in our AVT sessions or whatever that might be, so the family feels comfortable, so it's not like you're getting punished. Now you're being sent to social work or psychology. That's not the message we want to give. We want to be inclusive and know that this is very stressful. It's a lot of going on, and we all need to really be addressing that and also empathize with the family.
Yes, I have a question. I'm Alexandra Quitner for Dr. Costa. First of all, that was just a wonderful presentation. I congratulate you on that. I wanted to ask you about the two questions. Parcheesi as a way to measure maternal sensitivity. I wanted to ask you just how that works, as well as feasibility, because I think that PCIT is such a great intervention, so effective early on. I just wanted to ask you, in terms of incorporating it into a busy cochlear implant center, how you managed to do that, what kind of time constraints there were.
Thank you for that question, Dr. Quitner.
and for your work that you've done that's so important to think about the importance of these type of interventions. In terms of the first question, Parcheesi is a fairly well established. There's not a lot of measures looking at maternal sensitivity, and it is one that has been published. It is available, but the training on it is intense, as a lot of these are, because it's based on, you have to code videotapes. We had to have 2 coders that reviewed the tape and look at coder agreement, because you're looking at soft things that aren't, easily measured, and there's some subjectivity in terms of that, which is why the coding system is in place there. So it's reviewing videotapes, which takes a long time, including transcribing the tapes and then going through them and looking at those different dimensions. They're coded by people that have been trained and are deemed to be reliable coders in the Parcheesi coding system. I believe Dana Suskin presented at the last ACIA conference, and she used it as well in terms of maternal sensitivity. So it is one that's sometimes used, but there's not many measures for maternal sensitivity. In terms of PCIT and the feasibility, I love that you asked that question, because one of the things that I think there's 2 pieces. One is that we have to start making mental health a priority for these families, and we have to bring psychologists and social workers and mental health practitioners into the field and into the fold here. It's really important. I'm incredibly lucky that Nancy at River understands the importance of mental health and has always made it a priority, and will back up that belief by hiring a psychologist on her staff and making sure that these interventions are there. But I think it would do our kids and families well to have more mental health practitioners in cochlear implant centers across the country, because there's not many of us. The other thing, though, that I would like to say is that you would be shocked at how many PCIT centers are housed within university settings where there are cochlear implant centers. Miami has a huge PCIT clinic. Duke has a huge PCIT clinic there. There's one at Boston Children's. There's one in Michigan. They're all over the country. There's PCIT researchers everywhere. There's one at Hopkins and Kennedy Krieger. And so if anyone wants to do a collaborative multi-site study so we can really look at this, but if not, you should be referring your families to get this treatment, because you can go on the website, pcit.org, and look at PCIT treatment centers and certified therapists near you, and you can find resources there. Thank you.
Hi. I'm Anisha Preto, and I am a representative for MED-EL's Rehabilitation from their headquarters. My question is, and I have a question and a comment for Dr. Barker. I want to thank you for your presentation. It was really provocative and thought-provoking for me, and also the fact that you're drawing attention to qualitative research, because quantitative research also often gets the bulk of our attention in these kinds of venues, telling us whether our interventions are effective, but qualitative can tell us how our interventions, if they are effective, how they're effective, or how they're breaking down if they're not. So I really value that kind of work. Specifically, you brought up the term of identity and pervasive identity, and I wanted to just think about how persistent or pervasive these identities can be. Thinking from diagnosis through intervention, was there any thought given to taking multiple interviews to see if parents who are vulnerable remain vulnerable after interventions are given, or if parents who are proactive, do they stay consistently proactive? So just some thought there, your thoughts there.
Thank you. Your thoughts are good ones, and I share them. So in our lab right now, well, let me backtrack a little bit. Our perspective is that identity can change and is constantly changing. And also our perspective is that identity can be reflected in the ways that the stories are told, as I shared. So as you're suggesting, it's quite possible that the identities that parents are reflecting in their stories are very different when the diagnosis is happening and the decision to pursue cochlear implantation is taking place. So to get longitudinal data would be very interesting to see if the vulnerable parents are changing with the passage of time or changing with the help of mental health care providers is very interesting. We have some plans for future studies to actually look at identities and then help parents reshape the stories that they're telling. It's called narrative intervention. And so engaging in narrative intervention with families, and particularly parents who are vulnerable or are just at risk in general, and teaching them how to shape their stories in different ways, a la Welcome to Holland. This is an amazing new opportunity. We have hopes, and past research shows in mental health that can change the well-being and health outcomes of the parents and subsequently have very positive effects on the kids. So yes, I agree with you that identity is changing, and when we look at it in this developmental context, we are relying on the fact that it's always changing, but we do not have the data yet to see how it's changing or what direction it's heading towards, and that's a goal in our lab. Thank you.